Hi, everyone. Welcome back to Fem Health. Today, we are talking all things carpal tunnel with Dr. Julia Iafrate. She is a board certified sports medicine expert. So, Dr. Iafrate, I want to get right into it. Obviously, there's a lot more carpal tunnel now because of the increased use of devices. So, what can people do for carpal tunnel syndrome?
So carpal tunnel syndrome is very frustrating for a lot of people. It can happen for a number of reasons, and it can happen during different stages in our life. So first of all, what is carpal tunnel syndrome, right? It is basically a tension or traction or pressure on your median nerve. And I wear my watch to describe this to patients all the time because your carpal tunnel is basically like a watch band, and your median nerve sits underneath that watch band along with a bunch of tendons that allow your hand to do this function, to flex your fingers. In certain cases, especially with things like quick or aggressive weight change. So in pregnancy, we see carpal tunnel syndrome a lot, for example, as people get arthritis in their joints. So then the joints become a little tighter. And so then that space becomes a little bit tighter, or even with repetitive use and irritation. Anything that puts our hand in this position and keeps it there for a long time tends to irritate that nerve, and it gets compressed or choked. With carpal tunnel syndrome, the way that we can try to manage it is by alleviating some of that pressure that we're doing. So things like night splints are really helpful. So I will often have patients try out night splints before doing anything any more invasive. A lot of times that can help because it takes off some of the pressure. We tend to sleep like this when we sleep. Everyone likes a little snuggle, right? So we try to take the pressure off by putting our hand in this position and maintaining that neutral position. Other things that can be really helpful. So occupational therapy, which is kind of like hand physical therapy at the most baseline level, can be very beneficial. The point of doing occupational therapy is, again, trying to allow for gliding of that nerve within that space so that it's not getting adhered to the carpal tunnel. We also have different types of injections that we will do. I do all of my injections ultrasound guided to make sure I put them in the exact right spot. You certainly do not want to hit the nerve when you're doing a carpal tunnel injection. And we will hydrodissect the nerve, or basically inject fluid, maybe with steroid, maybe without, but inject fluid around the nerve to try to create more space for it so it has more mobility and easier movement. The last thing we end up doing, if all of those things don't work, is we consider a carpal tunnel release. And there are multiple ways to do carpal tunnel releases now. We can go into the OR, make a stitch about, or a cut about this big, and cut the carpal tunnel, this watch band, which you don't technically need. The other option is we can do a percutaneous version now of it. So we do it in the office. We make one small little incision, go in and hook. It looks like the hook that goes around that frog from all those TV shows we used to watch, but it's a little hook knife basically. And we go in, hook the carpal tunnel, and pull it towards us to open that space, which can alleviate a lot of people's symptoms.
So, what percentage of patients do you think actually need to go to that surgical level of intervention?
Actually, not as many as you might think. A lot of times it's because they've let the syndrome go on for a long time, that they've kind of gotten to a point where there is major damage to the nerve. The nice thing with carpal tunnel syndrome, if you can say that there's a nice thing, the good thing about it is we have something called an EMG where we can actually figure out how severe it is. So an EMG is called an electromyography. It's a needle exam. It's not the most comfortable thing in the world, but there's two parts to it. The first part is a nerve conduction study where we actually kind of shock the nerve a little bit and see if it's sending signals. And then the second part of it is we use little needles that almost look like acupuncture needles to try to see how much is the nerve telling the muscles what to do. Muscles themselves are stupid. They don't do anything on their own. They need nerves to tell them what to do. They're literally the brawn to the brains. So if there is not severe atrophy of the muscles, if the muscles are still getting information from the nerve, we technically don't need to do a carpal tunnel dissection or break the carpal tunnel or cut the carpal tunnel. Instead, we can usually manage it with some of these other options. It is only if everything fails, and these are like recalcitrant cases. So I'm talking maybe 10% of cases end up needing a release.
And for those watching who want to learn more about you and your practice and all the work that you do with the US ski team, where can we find you on social media?
Yeah, so I have an Instagram account. It is Dr. J, DOCTORJ NYC, because I practice in New York City. I also have an account on X at the new Dr. J. And I have, I have a webpage, drjuliaiafrate.com. In terms of the coverage I do with Ski Team, just follow us, follow US Ski Team, and you can see all the exciting stuff we're doing out on the mountains.